Thank you, Shobita, and at the outset, as part of the organizing committee, I extend my wholehearted welcome to all of the delegates who are present here. We are celebrating the 10th annual PGCon conference, and we have a very good number of set of speakers lined up for today and tomorrow's sessions. I request all of you to stay back and enjoy the learning process. So, with the permission of respected chairpersons, I'll start my talk, which is basically gastroparesis in diabetes. As Shobita has already mentioned, this is one topic probably we discuss less. The problem is there, but I feel that it's been underdiagnosed because probably the investigations modality to diagnose diabetic gastroparesis is difficult and not easily accessible. To start off with history, in 1958, the unanticipated discovery of asymptomatic gastric retention in patients with severe diabetes mellitus initiated investigations into gastric function, and the term gastroparesis diabeticum was coined. There is no clear consensus regarding the definition. The general consensus has now emerged. Basically, there is a delayed gastric emptying which occurs in absence of a mechanical obstruction. So, there are upper GI symptoms. We need to have an objective evidence of gastric emptying delay, and there should be an absence of mechanical obstruction to diagnose diabetic gastroparesis. Now, symptoms of diabetic gastroparesis do not just originate from the stomach, but also from the small intestine. And diabetic gastroenteropathy may be a more appropriate, more inclusive terminology. Now, in general, gastroparesis, not just diabetic gastroparesis, about 1/3 of patients with gastroparesis have diabetes. And diabetic gastroparesis affects around 20 to 50% of diabetic populations, more in type 1 diabetes, and also in type 2 diabetes with a longer duration, at least around maybe 10 years of diabetes duration. Female sex and obesity are high risk factors, and thankfully, at least in one case scenario, alcohol and smoking are not necessary. All the alcohols and smokers gathering. Mortality is high, not just because of diabetic gastroparesis, because once diabetic gastroparesis develops, that means the patient has developed all other complications of diabetes. The estimated 5-year survival adjusted for age and sex was 1.67% in one study. Coming to pathogenesis, basically multiple mechanisms have been linked to diabetes with gastric motor dysfunction. Most importantly is motor neuropathy. There is enteric neuropathy involving excitatory and inhibitory nerves, acute fluctuations in blood glucose, high oxidative stress, and very importantly, the loss of expression of neuronal nitric oxide synthase and loss of interstitial cells of vagina. Now, this is the basic pathophysiology of how gastric motility is controlled. GI sensorimotor functions are primarily regulated by the intrinsic or enteric nervous system, and this is modulated by the big brain or the parasympathetic and sympathetic nervous system. The enteric nervous system comprises the mesenteric plexus, which regulates motility, submucous plexus, which primarily regulates absorption and secretion, interstitial cells of vagina serve as pacemakers and also convey messages to nerve muscles. So basically, act to initiate peristaltic movements. Now, the movement of liquids and solids is very important while gastric emptying is considered. Liquids empty from the stomach in a more exponential manner. This is we have learned by scintigraphic studies. If you can see the extreme left-hand side of the bar, liquids go down in an exponential manner. Extreme right-hand side of the solids, which initially have a lag phase, and then there is a linear empty. Nevertheless, on an average, 50% and 100% of gastric emptying is completed in 2 and 4 hours respectively. If it is delayed beyond this, then definitely there is a delay in gastric emptying, and this is the basic investigation we need to understand whether there is delay in gastric emptying. Again, back to physiology. Now, this is how things work. We have the vagus nerve, the brainstem, parasympathetic line. There is initial funding accommodation when the food is ingested. It gives us space for digestion and absorption. Then there is funding contraction, which pushes down the food into the antrum. Here, peristaltic propulsion is taken care of by the pacemaker cells, interstitial cells of vagina, which pushes the food further down. Then there is mixing, grinding, trituration. Ultimately, the food particles are broken down to less than 2 millimeter size particles, and these small particles which get passed down the pyloric antrum. When the food is pushed down, there is again pyloric muscle relaxation, which helps the food transit to occur from the antrum to the pylorus. Now, all of these things are disturbed when a patient develops gastroparesis. There is venous neuropathy, impaired funding, accommodation and contraction. There is gastric dysrhythmia, there is loss of interstitial cells of Kajal, the compulsive movements are not there. The food doesn't undergo the trituration or grinding which should undergo. The food particles do not reduce the smaller size. And along with that, there is a pylorus puzzle, and thereby the food remains in the stomach for a long period of time, doesn't go down. Now, along with that, a lot of our diabetic patients are on multiple polypharmacy as well. These are other some drugs which can affect the motility. Opioid analgesics, anticholinergics, many patients are on depressants and tricyclic antidepressants, even calcium channel blockers, progesterone. These are the drugs which can further increase the symptoms of diabetic gastroparesis. Coming to clinical manifestations, the most common symptoms are nausea, vomiting, abdominal bloating, early satiety, upper abdominal pain and discomfort. And the Gastroenterology Association, they use a scoring system which is known as Gastroparesis Cardinal Symptom Index, traces the severity. And it includes 9 gastroenteric symptoms like nausea, vomiting, inability to finish a meal, loss of appetite, abdominal distension, retching, stomach fullness, excessive fullness, and bloating. Complications which might develop: esophagitis, melanoma stare from excessive nausea, vomiting, malnutrition, volume depletion with AKI, erectile disturbance, vasoar formation, and hyperglycemic emergencies as well. Now, for diagnosis, definitely as I mentioned, we need to rule out the mechanical cause. First and most important, we need to have upper GI endoscopy. If that is normal, then we go for functional test to assess gastric emptying. Scintigraphy, stable isotope breath test, as well as capsule motility test have been described. Problem is that they are a bit expensive, not easily available and accessible, and thereby we miss the diagnosis of diabetic gastroparesis frequently. Briefly about the tests we do in diabetic gastroparesis. Gastric emptying scintigraphy involves ingestion of a solid meal containing a radioisotope with short half-life, 99 technetium. Meal patterns depend on the country of residence. Western style meal, there are 2 scrambled eggs, 1 slice of whole wheat bread and 1 glass of skim milk. Asian style meals basically is a rice-based meal along with eggs, where the technetium 99 is labeled. Sometimes Ensure Plus meal have been used in some studies, but they are not very detailed. Upper limits of gastric retention at 2 hours and 4 hours should be 60% and 10%. That means 90% gastric emptying should be completed in 4 hours time. If it is less than that, that means there is gastric retention. So this is what it looks like when we do a scintigraphy. On the left side, you can see it's a normal gastric emptying. At 0 hours, the food is in the stomach. At 2 hours, there is around 67% emptying. Some amount of food is still in the stomach, mostly has gone down in the pylorus and duodenum. At 4 hours, there is complete gastric emptying of 100%. There is no food remaining in the stomach. What happens in delayed gastric emptying, as you can see, at 2 hours, the gastric emptying is only 29%, the entire food is in the stomach. And even at 4 hours, the gastric emptying is 57%. You can see that large amount of chunk of food is there in the stomach and small amount of food has reached down in the intestine. So this is a very important, very nice test, but problem is that it's not available everywhere. Stable isotope breath test, the gastric emptying, it is advantage is that it is non-invasive, similar cost to scintigraphy, cost to scintigraphy, and there is no exposure to ionizing radiation. The gastric emptying breath test incorporates a stable isotope carbon-13 in a substrate such as octanoic acid or spirulina pratensis. The principle underlying the test is that the rate of gastric emptying of the carbon-13 substrate incorporated in the solid meal is reflected by the breath excretion of carbon dioxide. The test is conducted over a 4-hour period after an 8-hour fast. The meal empties from the stomach. The octanoic acid or spirulina rapidly undergo digestion, absorption, metabolism to produce carbon dioxide, which is exhaled in the breath. And if in that period of time we can get the carbon dioxide, that means the meal has been completely digested, absorbed, and there is adequate gastric emptying. Wireless Motor capsule has been approved by US FDA. Once ingested, the wireless Motor capsule measures pH, temperature, and pressure throughout the GI tract. The completion of gastric emptying is demonstrated by an abrupt change in pH into the alkaline range when the capsule passes into the duodenum. So that is how the change in pH helps us to diagnose gastric emptying is adequate or not. Coming to differential diagnosis, very difficult to differentiate between functional dyspepsia. We have gastroenterologists here, they will be doing better. On the basis of the current definition, gastroparesis is basically indistinguishable from wrong functional dyspepsia and ileal gastric emptying. Pancreatic cancer sometimes may present in such a manner with a lot of GI symptoms, weight loss because of malnourishment is seen in both cases, and other differential diagnoses include chronic intestinal obstruction, rumination syndrome, adrenal insufficiency, hypothyroidism, dyslipidemia. These are easily can be identified and we can rule out basically the other causes can be ruled out. Patient presents with some symptoms. Management basically is not much elaborate. Most importantly, glycemic control, dietary changes, are we going to next few slides. Pharmacotherapy based mainly on the prokinetics, which will help the food to go down. And in very refractory cases, there are some interventions which are done by surgeons and gastroenterologists. So glycemic management is a mainstay. A1C has to be under control. Most of the guidelines now recommend based on timing range, at least less than 180 is preferable in most hours of the day. Pharmacotherapy, there is some controversy. Most guidelines recommend that oral agents should not be used. This is because the PK/PD of oral agents are impacted by the delayed gastric emptying. Biguanides can cause GI intolerance. Sulfonylurea has a risk of hypoglycemia. Alpha glucosidase inhibitors may be beneficial but cause diarrhea and abdominal distension. GLP-1 RA pramlintine again delay gastric emptying and therefore they should be avoided preferably. However, the risk of removal of GLP-1 receptor agonist should be managed against their potential benefits. Some studies have shown the benefits of pioglitazone in the treatment of gastroparesis, effect on restoring the GI neuronal nitric oxide synthase, and impaired nitric oxide synthase pathway in the mesenteric plexus and loss of neurons due to oxidative stress is assumed to contribute to gastroparetic symptoms, and pioglitazone may be beneficial in the treatment. Insulin still is the mainstay of therapy, especially in long-duration diabetes and type 2 diabetes. But in patients with gastroparesis, a mismatch between insulin action and glucose absorption can result in wide fluctuations in glucose, a lot of hypoglycemia and hyperglycemia have been noted. CSII, if possible, can be an effective option to maintain a good glycemic control, especially when the patient is having frequent hypoglycemia. Dietary modifications very important. Small meals, less in fat and indigestible fibers. Patients in advanced cases are advised to consume more of liquids and easily digestible food, which can easily pass. This is something we have to make change in diet. Fat and fiber intake minimize, avoid carbonated liquids and multiple small meals. Coming to pharmacology, if you can see, it's very surprising to see that even now, after so many years of having so many prokinetics, metoclopramide is actually the only FDA-approved therapy for treatment of gastroparesis. Other than that, we have domperidone and erythromycin. Metoclopramide can be used in the dose of 5 to 10 mg PD or TDS. Problem is that we cannot use it more than 12 weeks because of adverse effects. The patient can develop extracurricular side effects, hypercholesterolemia. Domperidone advantages is that it does not cross the blood-brain barrier, less likely to cause extracurricular side effects. Erythromycin again is off-label treatment, 250 to 500 mg thrice daily. Again, develops tachyphylaxis cannot be used beyond 1 month. Etoposide has been used, again is not FDA approved, but it is still being used quite a lot nowadays. Advantages of etoposide, again, less side effects. Dual mechanism of action, blocks D2 receptors in the esophagus and stomach, reduce dopamine control of GI motility and improves GI motility. It also causes acetylcholinesterase inhibition. Concentration of acetylcholine is increased in synapse, and this also improves the GI motility. Now, antiemetics, phenothiazines, antihistamines have been tried, but there are no RCTs to prove their efficacy. We have some newer drugs like ghrelin receptor agonist relavoreline, which stimulates gastric body and enteral contractions, excellent with gastric emptying, currently in phase 3 trials. Prucalopride can be used in some functional constipation. Again, it has been investigated and there are some beneficial results which have been seen in treatment of diabetic gastroparesis. Basically, it is a 5-HT4 agonist. Now, there are some studies and we have meta-analysis of relavoreline, more than 1,000 patients, quite satisfactory efficacy. Key adverse effects include sudden episodes of hyperglycemia, and this may be due to accelerated gastric emptying resulting in quicker nutrient absorption. There are meta-analysis of trials on 5-HT4 agonist, 5-HT4 receptor agonist, particularly Velucetrad, Felcitrad. They have also shown remarkable benefits in the treatment of gastroparesis, reduction in symptoms, and overall side effect profiles are quite acceptable. Among emerging therapies, tradipitant is one drug which is under clinical trial. It is an antagonist of tachycardia receptor 1. Mechanism of action is inhibition of substance P from binding to NK1R reduces symptoms of nausea, vomiting associated with these disorders. A lot of other drugs which have been studied, rifaximin, buspirone, and but not much clinical benefit which still is there to be approved by FDA for the treatment of gastroparesis. In refractory cases only, we have to move beyond pharmacotherapy to intervention. There are studies where intrapyloric botulinum injection have been given. There are symptomatic improvements in some patients, but two double-blind studies again did not show a reduction in symptoms. Interventional therapy, pyloric intervention, pyloroplasty to widen the pylorus and prevent spasm, pyloromyotomy or gastric paroral endoscopic myotomy. These are procedures where incision in the wall of the pylorus where endoscopic intervention has been done to improve the symptoms, to improve the passage of food from the stomach into the pylorus. Gastric electrical stimulation is approved by FDA in drug-refractory diabetic gastroparesis. Basically, it is a gastric pacemaker, a device implanted into the abdominal wall which generates 12 pulses per minute, just takes over the interstitial cells of Magellan's function. The study reported an improvement in 75% in 151 patients that have been studied. And interventional therapy to improve nutrition, these are only in extreme cases when the patient is extremely malnourished, unable to take anything directly. Direct percutaneous endoscopic tracheostomy feeding tube may be inserted to improve feeding and nutrition. And finally, this is the last resort where very seldomly done, gastrectomy seldomly used as a last resort for diabetic gastroparesis. All symptoms are totally refractory to all sorts of treatment. To summarize, up to 50% of patients with diabetes have delayed gastric emptying, which can be documented by scintigraphy, 13-carbon 13 breath test, wireless continuity capsule. Hypoglycemia, autonomic neuropathy, enteric neuromuscular inflammation and injury are implicated in the pathogenesis. Initial options include dietary therapy, improvement in oral nutrition, prokinetic agents, and more severe symptoms with interventional therapy. Promising newer therapies include ghrelin receptor and agonists like remamorelin and selective 5-HT receptor agonists. With this, I end my presentation. I thank you all for your patient hearing.